Aishwarya speaker is here.
Pooja, could you please confirm if we are live?
Yeah, just a minute. Oh, yes, we are live.
Very good morning, sir.
Yeah, morning, Aishwarya. Hi.
Sir, am I audible?
Yeah, you are.
Sir, we are live on YouTube, sir. So,
Okay.
can we start the session here?
Yeah, absolutely. We'll start. Okay. So I'll just share my screen.
Yes, sir. I'll just have a quick introduction. Give a quick introduction. Then I'll love to share.
Sure.
A very good morning. A very warm welcome to the 9th lecture of our gastroenterology series. Myself, Aishwarya Nair, welcome you all on behalf of the Pharm D Community for today's session on colorectal cancer by Dr. Nikhil Agarwal, sir. I'm thankful to all the participants from all over the country who have taken out this time, their time for the morning talk. Community has been created with a charter to provide free webinars by doctors and family doctors. Organizing this event would not have been possible without the wholehearted support of my core committee members and the newly joined family community members. I would like to take this opportunity to thank all the government officials and our speakers who have supported us throughout this socio-educational cause. A very big thank you to one and all who have supported us directly or indirectly. I'd like to mention about our upcoming lecture number 10, which is on gallstones. That is on the next Saturday, that is 6th March, and the timing is 6 p.m. I'm thankful to our speaker for today, Dr. Nikhil Agarwal, sir, who is one of India's eminent surgical gastroenterologist. So I would like to hand over the session to Vaishnavi Marathi to introduce our speaker for today morning.
Thank you, Aishwarya. I'm glad to introduce the speaker for today, Dr. Nikhil Agarwal, sir. Sir is Principal Consultant and Head, GI and Hepatopancreatobiliary Oncosurgery, Max Institute of Cancer Care, Max Saket, MS MCH GI Surgery, AIMS, New Delhi. Dr. Agarwal has expertise and over 15 years of experience in treating gastrointestinal, colorectal, hepatobiliary, and pancreatic cancers. He is one of the very few exclusive GI and HPB surgical oncologists. He has received surgical training and worked at prestigious institutions such as AIMS, New Delhi, SGPGI, Lucknow, Institute of Medical Sciences, BHU, SNUBH, South Korea, and Institute of Liver and Biliary Sciences, New Delhi. He established the Department of Gastrointestinal, HPB, and GI Cancer Surgery at Dharma Sheila Narayana Super Speciality Hospital, New Delhi. Sir has many publications and chapters in reputed national and international journals and textbooks to his credit. With this brief introduction, I'd like to welcome our speaker, Dr. Nikhil Agarwal, sir. Over to you, sir.
Thank you, Aishwarya, and thank you, Vaishnavi. Thank you, Vaishnavi, for a kind introduction. So I'll just share my screen and start the presentation. Yeah, so can you see my screen?
Yes, sir. The screen is visible, sir.
Yeah. So good Morning, everyone. Today we'll talk about colorectal cancer. So colorectal cancer is one of the important cancers which we deal with, and it's very common. And there is a very high likelihood of people getting it. What happened? Yeah. And am I audible, Aishwarya?
Yes, sir.
Yes, sir. You're audible.
Yeah. Okay. Sorry. So, so let's talk first about gastrointestinal tract. So what is a gastrointestinal tract? So our gastrointestinal system comprises of the organs, which you can see on the right side. So there is esophagus, there is colon, there is rectum. So colorectum is considered together as colorectum, and there is small intestine, there is liver, pancreas, and the gallbladder. Now, what it does, it mainly is incorporated with absorption of food and nutrients. And uh, when we focus specific to the colon is a 5 feet long organ, and it's comprises of colon and rectum. So if you can see my cursor, this is the whole colon. Colon has multiple parts, and the last part, last 15 centimeter of colon is called as rectum. So colon is divided into three. This is called as ascending colon. This part is cecum. This is transverse colon. This is descending colon. This is sigmoid colon and rectum, right? Now, if we look into the histology of colon, we will see that it is made up of 4 layers, right? So these 4 layers are mucosa, right? You can see the innermost layer here. This is mucosa. Then we have the submucosa. Then we have muscularis propria, and we have serosa. Now, why this is important, we'll come to that one in the staging of these cancers, because there is something which is called as TNM staging, which is important for the prognosis of these tumors, right? So the one component of TNM, which is T, depends on which layer of colonic wall these tumors have penetrated, right? So that's why we need to understand the colonic wall, and these are the 4 layers of colonic wall. Now, colorectal cancers begin in the innermost layer of the colon. So now we've just seen there are 4 layers of colon, and colorectal cancer begins in the innermost layer. Now, it can occur in any portion of the colon. We just learned that there are 4 portions of colon, right? And there is rectum, so it can occur anywhere. And if we look why colorectal cancer is an important cancer, so you can see that it accounts for over 9% of all cancers worldwide, right? So almost 10%. So every 10th cancer in the world is colorectal cancer. So this is the 3rd most common cancer and is the 4th most common cause of cancer death, right? It affects men and women equally. Now imagine the number, it occurs in 18 lakh individuals each year and causes 8,62,000 deaths, right? So it's a big disease, and every one individual out of 20. So if you take a group of 20 persons, one in that group will develop colorectal cancer eventually. So that's why we need to understand what it is, why we are talking about it, and why it is an important tumor to learn. Now let's understand the concept of cause and risk factor. So what is a risk factor, right? So risk factor is something which increases the risk of somebody developing a disease. So for an example, if somebody is obese, he has higher risk of cardiovascular disease. So obesity is a risk factor for cardiovascular disease. So similarly, there are many risk factors for colorectal cancer, right? And any cancer, or for that matter, any disease we understand is multifactorial. So there is not one factor causing that disease. There are multiple factors which cause any disease. And so the case is the cancer. So there are multiple causes of cancer. And the risk factors can be divided into modifiable risk factors and non-modifiable risk factors. So modifiable risk factors are something which we can modify. So for an example, say smoking is a risk factor for colon cancer. It can be modified. We can stop smoking. We can decrease the risk. Now, if somebody has a family history of colon cancer, that increases the risk of that person getting that cancer. This is not modifiable. We can't do anything about it. Now, again, the risk factors would be inherited, something which runs in the family, something which you get because of your family history, and something which is not related to family history, right? Now, we have to understand here that risk is something which increases the risk of cancer. So it means that if somebody has a risk factor for a cancer or a disease, it will increase the chances of that person getting that disease, but it will not make it sure that he will get the disease. So somebody will with a risk factor will not get might not get a disease, while somebody without a risk factor will might get the disease. So the risk factor only increases the chance of someone getting the disease. Okay, understood? So now let's see what are the risk factors of colon cancer. So risk factors of colon cancer, or for that matter, any cancer, is increasing age, right? So there are, as we age, our cells accumulate mutations, and these mutations will cause cancer. So the aging is directly related to cancer, right? Second is family history of colorectal cancer. So if somebody had a family member who had colon cancer, so family member is a first degree family member. So it includes parents and siblings, right? So if they had colon cancer, then that person, the chances of getting cancer is higher. Now, if we eat Western diet, so that is a processed diet, we generally call it junk food, then the chances of getting cancer is higher. If somebody had polyps in his colon earlier, which have been removed, again, the chances of colorectal cancer is higher. And if somebody had colorectal cancer earlier, somebody had been treated for colorectal cancer, his chances of getting colon cancer is higher. And another risk factor is inflammatory bowel disease. So you must be aware with the terms like ulcerative colitis and Crohn's disease. So these are diseases in which our colorectum, colon get inflamed. There is a lot of inflammation, and it increases the risk of cancer. Now, the risk of cancers in these diseases increases with the duration and severity. So the more duration of the disease and the severe the disease, the more the risk of cancer, right? Then there is diabetes, there is obesity, there is physical inactivity, and the smoking and alcoholism. These are the factors which will increase the risk of colon cancer. Now, there are some inherited colorectal cancer syndromes, right, in which there is a very high likelihood of the person getting the colon cancer. The two common ones, though common in the terms of overall, so if you look at overall number of colon cancer, less than 5% of the patients will have inherited colorectal cancer syndromes. 95% will have de novo cancer, in which there will be no inherited syndrome, right? So there are two common syndromes. One is hereditary non-polyposis colorectal cancer, HNPCC, or Lynch syndrome. In this, people will not have polyps, but they will have cancer. Second is FAP. In this, the patient will have multiple polyps, thousands of polyps across the colon, and they have a very high risk of developing colorectal cancer. Rather, they will develop colorectal cancer. And there are some other rare inherited syndromes like Peutz-Jeghers and MYH associated polyposis. Now, these colorectal cancer develops slowly, right? So it's not that, you had a normal colon one day and second day you'll have a colon cancer. So it's a slow process. It takes decades, right? 10 to 15 years for a cell from a normal epithelium. We remember that colorectal cancer developed in the inner lining of the colon. So from a normal epithelium to cancer development process takes around 15 years, 10 to 15 years. Now it goes through a sequence which is called as adenoma carcinoma sequence. So first we have some mutations in the normal cells. You can see normal cells will continue to develop mutations and they'll accumulate mutations. So these are the names of mutation. If you can see here, KRAS, BRAF, APC, beta-catenin, P10, P53, right? And there are pathways through which, so WNT pathway, EGFR pathway, right? So these are the pathways and these are the mutations through which a normal epithelium will gradually become an adenoma, from there to a large adenoma, from there to a cancer, and from there to metastasis. So all these cancers will go through adenoma to carcinoma sequence over a period of many years. Now, once somebody has colon cancer, what are the signs and symptoms that person will have? Right. So the signs and symptoms of colon cancer include altered bowel habits. Right. So altered bowel habits means that every individual has some frequency of stool, some ways in which he generally passes stool, and that will change. So if somebody used to go to stool once a day, he might say that, nowadays I have changed it. It has become twice or thrice, or sometimes I get constipation, sometimes I get diarrhea, and uh, these things are persistent, right? So everybody will have some upset of intestine, some diarrhea, some constipation at some point of time. But for patients with colon cancer, these symptoms doesn't go away. They last for some time, right? Patient might feel a lot of loss of weight, loss of appetite, right? He will feel fatigue. There could be anemia. So anemia occurs because of loss of small amount of blood. So it's a raw area, so it will lose blood. This blood the patient will pass in the stool, but sometimes he'll be able to see, sometimes he'll not be able to see. And this, because of passage of blood, patient will develop iron deficiency, and the iron deficiency will lead to anemia. So in larger tumors, there could be pain or discomfort. The tumor can block the intestine, which will again cause bloating of intestine, pain, discomfort. And if we examine these patients, so some of these patients who has advanced tumor will have a mass in the abdomen. Right. So how do we diagnose once we suspect that this patient could be having colon cancer? Right. So physical history and examination is a very important aspect of clinical history taking, of establishing a diagnosis. So we see the patient, we ask them questions, we understand their symptoms, we look for signs, right? Like for an example, we can look for an abdominal mass on examination. We can look for signs of anemia. We'll do a rectal examination and see if there's any growth there. We can also do a fecal occult blood test in which the stool is tested for blood. Right. If you remember, I told you in previous slide that you lose small amount of bloods through these tumors, which is not visible to our naked eye, but by doing some test we can detect. So that is called as fecal occult blood test. So these are supportive things, but what establishes the diagnosis of colorectal cancer is colonoscopy. So colonoscopy is a procedure in which a thin lighted tube is passed inside the colon, right, through the anal canal, and it will project the images of inside of colon on a screen that you can see on the figure on the right side. So on that screen, you see the inside of colon, and if you can see a polyp or a growth or a cancer, you can see it, you can biopsy it. And biopsy means that there is a forceps-like thing attached at the tip of colonoscope. It will take a small tissue, a small piece of tissue from the colon, and then it is fixed and sent to the pathologist, and the pathologist will see it under the microscope, and then he'll confirm the diagnosis. Right. So before doing colonoscopy, we have to prepare the colon. So we have to give these patients some medications which will purge the colon of all the content so that it becomes clear, and then the endoscopist or the gastroenterologist can see the colon from inside. So we understand that once we have cancer, it has propensity to spread. The tumor cells break away from colon tissues and they spread. Now, how do they spread? They can spread through bloodstream, right? So every organ is supplied by blood vessels, and the blood courses through those organs. Then it can metastasize through lymphatic system or sometimes directly through the tissues. Right, so these are the three ways it can spread. The spread could be local, the spread could be distant. The local spread is through the layers of the colon to adjacent organs and into the lymph nodes, and the distant spread is to the liver, lung, and peritoneum. Right. So for staging these cancers, we first do blood tests. So in these, we'll see counts and liver function tests and kidney function tests. These are the basic tests. Then most of these tumors will produce a substance which is called as carcinoembryonic antigen. And there are blood tests which will detect the CEA levels in the blood. This is more of a diagnosis supporting type of thing. And this is very important from the point of view of following up the patient, because we cannot repeat a CT or a PET scan every 3 months, but we can repeat a CEA every 3 months. Then we do one of these tests on these patients. So either we do a CT scan or MR or PET scan. Now, if you understand CT scan, right? So in CT scan, the patient is placed in a scanner, right? And it's a beam of X-ray is directed towards the patient, and it will acquire images of inside of the abdomen. And these images are computer processed, and you get an image like this, which you can see here. So we can see the inside of our abdominal cavity. And if there is a tumor, if it has gone to liver, if it has gone to peritoneum or other parts, we can see. Right? Similarly, MRI is on the right. Right? MRI uses magnetic waves instead of X-rays, and MRI is more useful for rectal cancer. Right? So for an example, in this image here on the right side, you can see there is a polyp. Yeah. So just pause it at the level of polyp so that you can appreciate what I want to show. Okay, it's not stopping there. So it will just show you the polyp, and then PET scan is slightly different. PET scan is based on the premise that these cancer cells take up a large amount of glucose, right? So we tag this glucose with some particles which are lighting up on the scanner. So this is called as radioactive glucose, 18F fluorodeoxyglucose. So it will bind to the tumor, and then we scan with a special scanner in which it will show as bright images, and then this is combined with CT scan images to show a PET scan image, right? So after doing this staging workup, we generally put these tumors into 3 buckets. So it's either localized cancer, so which is localized to the colonic wall. It could be very much inside, or it could have penetrated through the walls. You can see that in the images on the right, or it could have gone to the lymph nodes nearby or in the adjacent wall. So that is called as regional spread, or it could have gone to the liver, lung, or peritoneum. That becomes a metastatic disease or distant spread. So because the treatment of these patients depend on which bucket these patients are in. So if it's a localized disease, we treat them differently. It's a regional spread, we treat them differently. And if it's a distant spread, we treat them differently. Now, for exact classification of these tumors, we use what is called as TNM classification, tumor node and metastasis classification. Now, this has been developed by American Joint Committee on Cancer, and this is called as AJCC cancer staging. Now, it's based on 3 important parameters, which is called as TNM, tumor node and metastasis, right? So tumor means, now go back to the third slide. I showed you the walls of the colon. So there are 4 layers of colon, and T stage depends on how far the tumor has grown across the wall of the colon, right? So if you remember, there was 4 colons, and the colon cancer arises in the inner layer of the colon. So from inner layer, it has to grow to 2nd, 3rd, and 4th layer, right? So we have to see on histopathological examination which layer it has grown into. So that will give us the T stage. So based on that layer, it is called as T1, T2, T3, or T4. Similarly, whether it is spread to nearby lymph nodes, so that's called nodal staging, denoted by N. So it's N0, N1, N2, or it could be a tumor which has spread to liver, right, or lung, or peritoneum. It becomes a M1 disease, metastatic, right? So that's how we classify these tumors. Why do we classify them? One, it's important from the point of view of treatment, because the treatment of each stage is different. And 2, from the point of view of prognosis. So if a patient of colon cancer asks me, doctor, what are my chances of making through this cancer on a longer term, or how long I'm going to live, how many months, how many years. So the answer to that question will come from what is the stage of the patient. So this TNM staging is something which will classify exactly what stage the patient is in, and then based on this information, I can tell the patient how long he's going to survive, right? So this is an infographic in which you can see how we label these patients as T and M, right? So M is not depicted here, but T you can see very early going through the submucosa, T1, crossing the submucosa and reaching up to muscularis propria, T2, subserosa is T3, and going across the serosa is T4, right? And again, if these are negative nodes on the left side and these are positive nodes on the right side, right? So if a couple of nodes are positive, then it's N1 disease. If many nodes are positive, it's N2 disease, right? So that's how we classify. Now we have detected a tumor, we have diagnosed it, we have staged it, we have classified it. So what do we do next? Obviously, we have to come to a treatment. Now, treatment depends on whether there is a localized disease or a locally advanced disease or a metastatic disease. So for localized disease, the standard treatment, and it is the primary treatment, it is the only curative treatment, that is surgery. So we operate these patients, we remove the colon and which contains the cancer, right? Now there are various names of the surgery. Broadly, we call them colectomy, and there are different names for rectal cancer. We call them anterior resection or APR or low anterior resection. So broadly speaking, what we do, we remove the part of the colon which contains the cancer along with the lymph nodes, right? So I'll tell you in the next slide, but then this could be a partial colectomy in which we remove a part of a colon, or a total or a subtotal colectomy, right? So in this picture, we can see there was a tumor in the right side of the colon, and we have removed the right side of the colon. Now a question will come to your mind: why right side of colon? Why not only the small part of colon which bears the which bears the cancer, right? And second is your subtotal colectomy, in which the major part of colon is removed. So why do we subtotal or total colectomy when there are multiple tumors in the colon? Or if you remember, there are some hereditary colorectal cancer syndromes like FAP and HNPCC. So in FAP, there are polyps across the colon, and say if some part of colon has developed the cancer, then we remove the whole colon, because the remnant colon will also develop the cancer eventually, right? So this is the idea behind doing a subtotal colectomy. Now, what we do in these colectomy, we remove diseased colon. And why do we remove right colon or left colon? Because we have to remove the blood supply of that part of colon. So if we are removing a part of the colon on right side, so we have to go to the base of that colon from where the blood supply isn't coming, because all the lymph nodes are along the blood supply, right? So along the vessels, and we have to cut that blood supply, that vessel. So for an example, right colon is supplied by ileocolic and right colic artery. So we have to divide these vessels at the base of the colon, base of their origin. And then we have to remove all the lymph nodes along with that. So if you cut ileocolic artery and right colic artery at the base, so you have to sacrifice the whole right side of colon, not only the portion of colon which has the cancer. So that's why there are standard names for this procedure. And then what we do, we restore the intestinal continuity by joining the intestine back together. You can see that here, right? So in this image, you can see the right side of colon has been cut, and the small intestine here has been joined with the remnant colon, that is the transverse colon, and this is called as ileotransverse anastomosis, right? And there are various names. So it could be a right hemicolectomy when we remove the right side of colon. It could be a left hemicolectomy when we remove left side of colon. When we remove sigmoid colon, it's called sigmoidectomy. When we remove transverse colon, it's called transverse colectomy. And if we remove a larger side part of right or left colon, it is an extended right or left hemicolectomy. And when we remove a part of rectum, upper rectum, along with distal most colon and sigmoid, that is called as anterior resection. When we remove a larger part of rectum along with sigmoid, right, that is called as anterior resection. And when we remove the whole rectum along with the anal canal, it's called as abdominoperineal resection, right? So again, you can see right hemicolectomy, transverse colectomy, left hemicolectomy, sigmoid colectomy, anterior resection, low anterior resection, and APR. Okay. So how do we operate these patients? So we all understand open surgery, right? You give an incision over the abdomen, you open the abdomen, you see the colon, you divide the blood supply, and then you remove that part of colon, right? Now we do the same procedure through laparoscopic surgery, which is also called as keyhole surgery. Now what we do in keyhole surgery is that we don't give larger incisions, we make small holes in the abdomen, and we operate through these holes, and then we divide the blood supply, we lift off the colon, and we do the same procedure through these small holes. Now, why do we do this? Yeah, because patients get some advantage. The risk to the patient is less and the pain is less, the recovery is much faster. They go home earlier, they start eating earlier, they can go join their work earlier, and obviously it is a cosmetic thing, so it also give a cosmetic advantage to patient. They don't get a long scar, there are few small holes through which the surgery is done. Now that finishes the discussion of localized cancer. Let's talk about advanced cancer. So generally from other cancers, we understand the moment we have metastatic disease, a disease which has spread to other organs, we think these patients are incurable, but not for colon cancer. So patients, if they have limited spread to liver or lung or even peritoneum, these patients can be treated and cured with some advanced procedure which would involve removal of part of liver which contains the tumor or lung which contains the tumor, or doing a procedure called a cytoreductive surgery and hyperthermic intraperitoneal chemotherapy or HIPEC, in which the whole peritoneum containing the tumor is removed and the remnant cells are killed with a heated chemotherapy solution, right? So these are the options we have for advanced cancer. Now, despite all these advancements, there will be some patients whose cancer would have spread to a point where surgery cannot be done, they cannot be cured. So these patients are given palliative chemotherapy. Palliative chemotherapy will prolong their survival. Now, not only these patients, patients who are operable or operated. So very early patient doesn't require any treatment, but some patients whose tumor is T3 or beyond or has spread to adjacent nodes, they require chemotherapy before or after surgery. So chemotherapy when before surgery is called as neoadjuvant chemotherapy, and after surgery it is called as adjuvant chemotherapy. So in colon cancer, we generally give chemotherapy after surgery. So that's called as adjuvant chemotherapy. Now, there are various chemotherapeutic drugs which are used in colon cancer. I'm not going to go into details of that. That is the domain of medical oncologist. But generally, these drugs are 5-fluorouracil, oxaliplatin, irinotecan, along with some targeted agents, right? So these targeted agents are monoclonal antibodies which target some specific tumors and block the pathways so that the tumor cells doesn't grow. So it could be a VEGF inhibitor such as bevacizumab, EGFR inhibitors such as cetuximab, or kinase inhibitors, right? Similarly, there's a newer thing which is called as immunotherapy, and immunotherapy use patients' immune system to fight the cancer rather than killing them through chemicals, right? So for an example, immune checkpoint inhibitor therapy is a form of immunotherapy for colon cancer. And let's talk about radiation therapy. So in this, beams of intense energy are used to kill cancer cells, right? So mostly these are X-rays, which is given to tumor through a machine in a very concentrated way uh, from all sides, so that only tumor gets the X-rays while not the adjacent tissues. Now, radiation therapy doesn't have much role in colon cancer, but it's a very important component of treatment protocol in rectal cancer, right? So most of the rectal cancer we'll treat today will get their radiation therapy before surgery. So we give them radiation therapy, we wait for some time, and then we operate rectal cancer patient, right? So this sums up the treatment of colorectal cancer. Not only treatment, everything about colorectal cancer. Now, there is a very important concept is screening, right? So for that is for all many diseases, but say for an example, for colorectal cancer, we do screening to detect patients in an earlier stage. So we understood there that if we detect patients earlier, their treatment is better, their outcome is better. So if to detect these patients earlier, we have to screen people for colorectal cancer. Now, screening doesn't mean detecting cancer in symptomatic individuals. Screening means detecting cancer in patients who are not symptomatic, right? So it means you cannot obviously screen each and every individual in a population. So the screening is done in selected population. A population which is high risk for a particular cancer is screened for that particular cancer. So how do we define which is a high risk group for colorectal cancer? So that's here, right? So if somebody who's over 45, somebody who had family history of cancer, now you see it will resonate with what I talked about in risk factors. So these are the risk factors for colon cancer, right? Somebody who had a personal history of colorectal cancer or polyp, if somebody had a long-standing inflammatory bowel disease, if there was a hereditary colorectal cancer like FAP or HNPCC, or if there is a history of radiation to the abdomen or pelvis. So these are the people who should be screened for colorectal cancer. And if we screen them, we can find colorectal cancer earlier, the treatment will be easier and the outcome will be better. Right, so that sums up my presentation for colorectal cancer. I hope that was helpful. Thank you very much.
Thank you so much, sir. Thank you for delivering such an informative and elaborative session on colorectal cancer. So
Thank
as
you.
we were streaming live on YouTube, we have received a couple of questions from YouTube Live and via our registration forms. So can
Yeah.
we take a couple of them?
Yeah, absolutely.
Yeah, thank you, sir. So the first question is from YouTube. The participant has asked, why do patients with type 2 diabetes have an increased risk or poor prognosis of colorectal cancer?
So see, prognosis is not poor. Prognosis is same stage to stage, right? Now, risk factors, very difficult to say why. There are various theories of obesity or diabetes increasing the risk. But in a nutshell, I can say that whenever you have some abnormality in the body, it increases of chances of our cells having those mutations, and these mutations lead to colon cancer. So the cause is more at the molecular level, the changes in the DNA of the cells, right? So that's how these things cause colorectal cancer.
Okay, thank you so much, sir. The next question is from a registration form. The participant has asked, can NSAIDs decrease the risk of colorectal cancer?
So the answer is yes. So there is some data that NSAIDs is can decrease the risk of colorectal cancer, but the data is not that strong, as strong that it can be used in a community setting. So we don't usually prescribe NSAIDs as a preventive treatment modality. But yes, there is some data that it can decrease the risk of colorectal cancer, but you shouldn't take it. The data is not strong because there are other risks of NSAIDs, which you probably better understand, right? So it can cause renal diseases and many other diseases. So it's not routinely recommended.
Okay, thank you so much, sir. So the next question is, some studies suggest working a night shift regularly might raise the risk of rectal cancer. So how true is this?
So I'm not actually aware of any such studies. But generally speaking, see, if you have a schedule which is not very right, so it increases your stress, it increases the stress hormones in your body. And I didn't talk about prevention of colon cancer in this presentation, but like that's a very important point. And if I talk about prevention of colorectal cancer, then I say it's about, a healthy lifestyle. So a healthy lifestyle means you eat well, you sleep well, you have less stress, you do some exercise, and working in night shift will probably interfere with all of these, right? So you will be not eating healthy diet when you're working at long hours, you will probably have more stress, you will have lack of exercise, and so put all things put together will probably increase slightly your risk of cancer. Per se, night shift shouldn't increase your risk significantly.
Okay, thank you so much, sir. The next question is again from YouTube. The participant has asked, are low vitamin D levels a risk factor for developing colorectal cancer?
Yes, there is again very soft data which has suggested that low vitamin D levels increases the risk of colon cancer, right? But again, the data is not as strong that you start recommending vitamin D to each and every individual. But yes, it has been listed as one of the risk factors.
Okay, thank you, sir. The next question is, due to colectomy, what are the lifestyle modifications that can be done so as to overcome the pain and discomfort after the surgery?
So, see, there are various types of colectomy, and generally speaking, for segmental colectomy, so if you remember, I said there could be right, left, transverse, sigmoid. Generally, no lifestyle modification is required. The patient is as good as they were before surgery, and especially with laparoscopic surgery, the outcomes are very good. But patients with major colectomy, say subtotal colectomy, will require some lifestyle modification because their stool frequency will be higher because the large part of colon would have gone. So, like, not much actually, they cannot do much about it because their stool frequency will be higher, but you can't do anything by changing your lifestyle. So, they actually will be eating normally, drinking normally, and having their normal life. So they actually don't need to do anything specific in their lifestyle modification. Their life will be slightly changed by increased stool frequency, and that's it.
Okay, thank you so much, sir. The next question is there any class of cardiovascular drugs which needs to be contraindicated in a patient who is suffering from colorectal cancer?
No, I'm not aware of any such drug.
Okay, thank you, sir. The next question is, how does serum CEA serve as a marker for assessing the treatment outcomes?
Yeah. So that's a very important question from a clinician's perspective because see, CEA levels are raised in colon cancer. So one, it's a marker for diagnosis in terms of, you suspect a colon cancer and a CA is raised, so that supports the diagnosis. Two, it's a prognostic marker. So a patient with low CEA versus a patient with high CEA. So somebody with a low CEA will have a better outcome. Three, from a follow-up perspective. So these patients who had colon cancer, they underwent treatment. Then we see what has happened to the CA level. So it will generally fall. And we have to again follow them up for recurrence of cancer. Now, how do we follow them up? We have to do some tests. So the tests are generally like a blood test and a scan. So you cannot do a CT scan every 3 months, right? So we do those scans annually, but you can do a CA every 3 months. So that's how we follow them up with the CA. So we do 3 monthly CA initially, then we decrease the frequency to 6 months, and then we decrease the frequency to 1 year. So that's how CA helps us in every stage of cancer treatment.
Okay, thank you so much, sir. The next question is, what are the genes which commonly get mutated? And can you please brief us about the pathological mechanism involved in the same?
Yeah, so see these genes, one of the, I'll have to probably go back to the slide because it's very difficult to remember all those names. So one of the common genes is APC gene, right? And then there is P53 gene, and then there is P10 gene, then there is beta catenin, KRAS, BRAF, okay, and SMAD4, TGF. So these are the genes. So initially probably there is a sequence. So not it's exactly it will go by the same sequence all the time. The sequence will vary depending on patient to patient. and tumor to tumor. Some patients will get some mutation first, some patients will get some mutations later, and the cancer will occur only some number of mutations accumulate, and then it metastasizes when further mutations take place. And there are various pathways of them accumulating these mutations. So these pathways are like WNT pathways, EGFR pathways, TGF beta tumor signaling, chromosomal instability, and COX2 overexpression. So these are the genes and these are the pathways through which uh, a normal cell will first become an adenoma and then a carcinoma.
Okay, thank you, sir. So there are a few more questions. Can we take them?
Yeah, please, please.
Okay, thank you, sir. So the next question is, what are the chances of metastatic colorectal cancer being cured, and what are the monitoring parameters and frequency in such cases?
Yeah, so chances, if we see statistically overall put together, the chances would be around, say, 30%, right, of a metastatic colorectal cancer being cured. Now, a cure means a patient which we would have treated and will be cured of the disease. So they will not have recurrence of the disease. So that number is, say, 20 to 30%. And sorry, what was the second part? There were two
Part
questions.
was the monitoring and the frequency of the tests.
Yeah.
Right?
Yeah, so monitoring, so I partly told about that in the CEA discussion. So monitoring, we monitor these patients every 3 months, right? So initially, like we would have scanned, we would have operated, and then in the first year, so this patient would have received adjuvant chemo depending on their stage. So then we do a blood test, CEA, ultrasound, and chest X-ray every 3 months. A colonoscopy has to be repeated at 1 year and then every 5 years. And a scan means a CT or a PET scan has to be done annually for first 5 years. Then second year, we decrease the frequency from 3 months to 6 months, right? And then third year onwards, it's annual only. Right? So this is how we monitor those patients. And the idea about monitoring these patients is that once we have a cancer recurrence, we want to detect that recurrence early so that we can treat it. So suppose I treated a patient with colon cancer and he presented with a raised CA. I scanned that patient. I found there was a single deposit in liver. I will go ahead and resect that liver lesion also in an aim to cure the disease.
Okay, thank you, sir. So the last question is, does rectal surgery affect the fertility of the patient?
So rectal surgery per se doesn't affect it much, right? But whenever we talk about rectal cancer treatment, if you remember, I told radiation is a very important part of rectal cancer treatment, right? And this radiation and chemotherapy affect the fertility of the patient. So generally we involve, when we are treating young patient whose families are not complete, we will involve our fertility specialist. So we will do sperm or ovum preservation in these patients before starting the treatment.
Okay, thank you so much, sir. That brings us to the end of the Q&A session. I would like to thank you for taking our time and answering the queries of our participants. Thank you, sir.
Thank you very much.
I now hand over the session to Aishwarya to please deliver the vote of thanks.
I would like to take this opportunity to thank our speaker for today, Dr. Nikhil Agarwal, sir, for this marvelous and enlightening session. I'm sure that all of us gained immense knowledge through this session, and it will be useful for all the Pharmd and the medical students attending this session. On behalf of the whole Pharmd community and all the participants, I would like to thank our speaker for today, Dr. Nikhil Agarwal, sir. A very big thank you to sir. Even during this difficult times of COVID-19, you managed to deliver this session for the benefit of all the students. Lastly, I would like to thank all the participants who attended this webinar. Thank you so much. Hope these series of webinars help you during your hospital postings. Thank you so much, sir, for taking out time.
Thank you, Aishwarya. Thank you, DFARM community. Thank you very much. It was pleasure.
Participants, the announcement about the first assessment has already been made yesterday. So I would just like to repeat that announcement today so that there is no confusion amongst you all. So the announcement is that the first assessment is scheduled on 4th of March, that is Thursday. The link will be open till 5th March, 8 p.m. Kindly make a note of the timing, 5th March, 8 p.m. The portion for the same is PUD, liver cirrhosis, malabsorption syndrome, chronic pancreatitis, celiac disease, and acute pancreatitis. So I request all the participants to make a note that this assessment would be posted on our Telegram group, that is the official group of Pharm D Community. So everybody is requested to access the link of the Google Form from that particular Telegram group and solve the quiz before 5th March, 8 p.m. Do consider, like since we're given a very long time span of 24 hours, we do hope that everybody understands that there would be no extension in the date or in the time. So I request everybody to access the link before 5th March 8 p.m. and complete your assessment. In the assessment, 50% is the passing criteria. So I request everybody to kindly go through the lectures, thoroughly, and then attempt the quiz. It would be a single attempt quiz. You cannot have multiple attempts, and that would not be considered too. So this is the announcement that had to be made today. Apart from this, I would also request all the participants to complete their attendance criteria too. Though even if you'll pass in the exam even with a 90% or 100, but if your attendance criteria is not completed, you would not be eligible for the certificate. So it's my humble request to everybody, instead of messaging us personally or dropping an email for the attendance criteria, it is better if everybody actually attends the webinars. You can either attend it live or it also remains on YouTube. So you can choose any mode which is comfortable for you. But I would request everybody to attend at least 90% of each session so that you complete your attendance criteria. And apart from that, you have to score 50% or above in each and every assessment. So kindly make a note. The assessment is to be released on this Thursday. It would be open for 24 hours. And the timing is, and the closing timing is 5th March, 8 p.m. Thank you so much once again for joining. We do appreciate everybody for taking out time and joining for this morning talk. Hope to see you all for our next lecture, which is on this Saturday, which is by Dr. Neeraj Vinaya Kumar. The topic is gallstones and the timing is 6 p.m. Thank you, everybody. This is Aishwarya Nair, and I sign off on